please join me in welcoming our panelists.
Okay, pointed at. Oh, did I go too far yet? Here we go. Great. All right, so the title of this presentation is on regulating nurse practitioners in Michigan, less regulation, more competition. And I've been a nurse practitioner for 30 years, and I am the director of a graduate nurse practitioner program. So I want to give a little biographical snapshot because I'm not sure how many of you actually understand the role of the nurse practitioner, and then my co-presenter will talk more about regulation. So nurse practitioners have provided high quality primary care, acute care, and specialty care services for more than 50 years. We celebrated our 50th anniversary in 2015. All nurse practitioners, is there feedback or am I just hearing it right here? No, okay. All nurse practitioners have advanced clinical education and training, and they're competent to provide health care beyond their initial registered nurse licensure. They also have a master's or a doctoral degree, and they graduate from a nurse practitioner program. Many nurse practitioners have a unique perspective of more of a care and cure perspective. So NPs diagnose, treat, they manage acute and chronic illness, and they oftentimes focus on health promotion and disease prevention. They're licensed in every state, including the District of Columbia. And in 2015, there were 5,500 of us in Michigan. And in the United States right now, there's 205,000 of us. So that's quite a few NPs. Does anybody know how many physicians are in the US? Yeah, so think about that. So 700,000 physicians, 200,000 NPs. There's about 100,000 PAs out there. The NP profession is predicted to grow to around 250,000 by the year 2020. And that's because graduations have accelerated at nursing programs across the country. So quite a few of us out there. A little bit about state licensure. And you have all this, so I'll try to be somewhat brief. But nurse practitioners practice under the rules and regulation in the state in which they're licensed. So in Michigan, LARA, in conjunction with the State Board of Nursing, regulates nurse practitioners. And LARA will issue a nurse practitioner a specialty certificate, and they do that to RNs who have passed who have graduated from a program, so they have advanced training and education, and they've passed a national certification, board certification exam. So in order to get that specialty certificate, you have to have passed a national certification and also be an RN and also have a graduate degree. So if all those things are present, the Board of Nursing will issue you a specialty certificate, and that will be attached to your registered nurse license, and you will be the only one who can call yourself a nurse practitioner, a nurse anesthetist, or a nurse midwife if you hold that specialty certificate. So we do have title protection in Michigan. Those are the only people that can call themselves a nurse practitioner. Scope of practice, just real briefly. Nurses, like all other health professionals, are responsible for knowing their scope of practice and when they're within it. In Michigan, the Public Health Code defines the scope of practice for RNs, and they're licensed to practice independently. If they're doing any medically delegated functions, such as prescribing, they will need to be supervised by a physician. Likewise, nurse practitioners are not dependent on physicians either for supervision or delegation. It is not a subset of medicine, and we're independently licensed to practice nursing. We're educationally prepared, and we have the clinical experience behind us to do the practice of nursing, and it does not need to be delegated. Real quickly about quality and cost effectiveness. There's 40 years of research on this, and I have the bibliographies on your table as well. Most of them have 30 or 50 articles. And there's been an overwhelming number of research studies that supports that nurse practitioner care is safe, it's effective, it's patient-centered, it's timely, it's efficient, and it's evidence-based. In many of the studies, the care is comparable to physician care. Some of the studies show that that NPs focus more on prevention. So NPs are a proven response to the evolving trend towards wellness and prevention, driven by consumers. In 1981 and 1986, the Office of Technology Assessment did several studies on NPs that provided equivalent and showed that NPs provided equivalent or improved care at a lower cost than physicians. And many physician practices that employ NPs have potentially decreased costs as well. The bibliography is just extensive, so take a look at that if you have a chance. A little bit about insurance reimbursement, and I want to be brief on this. All major insurances reimburse nurse practitioners directly. There are a few little problems with that. The last bullet down there, nurse practitioners usually have to have a collaborating physician in Michigan to get reimbursed if they've ordered a diagnostic test and they've interpreted that test. So Michigan is a little behind the times in that. HMOs that accept Medicaid usually will allow NPs to be direct providers as well. They'll have provider status. So the regulatory environment in Michigan is a lot different than the other states. And I just want to talk about the three categories for the regulatory environment for nurse practitioners. The American Association of Nurse Practitioners describes it as full practice, reduced practice, and restricted practice. 21 states in DC have full practice for nurse practitioners. And what that means is the state practice laws and the licensing laws allow for nurse practitioners to fully evaluate, order, interpret diagnostic tests, initiate, and manage patients. That includes prescribing. This is the model that's recommended by the Institute of Medicine and also the National Council of State Boards of Nursing. 17 states have reduced practice. And in those states, the laws actually reduce the ability of nurse practitioners to engage in at least one aspect of practice, or they require a collaborative agreement with another health professional for the nurse practitioner to practice. They have some type of limit on the scope of practice for nurse practitioners. And then the last category is called restricted practice. There's 12 states, Michigan is one of those, and in that state, the laws severely restrict the ability for nurse practitioners to engage in one element of practice, or they require supervision, or in Michigan, delegation for a lot of activities that nurse practitioners would do to provide care. They may require that we have a collaborative agreement with an outside member of a healthcare team in order to provide patient care. I think this map really, shows it very nicely, that you can see that Michigan is a restricted or a red state, and we're surrounded by reduced practice states, and most of the rural states in the U.S. are full practice states. So I'm going to let Tom talk a little bit more about the regulation.
Thank you, Connie. I start off by saying that Michigan is one of the regulatory dirty dozen. One of the 12 states that are presently classified as restricted practice. So what does that mean? So in Michigan, nurse practitioners cannot autonomously prescribe pharmaceuticals. They're restricted from ordering patient restraints and also prescribing physical and speech therapy for patients. And lastly, the state of Michigan does not define the practice of advanced practice registered nursing for NPs, clinical nurse specialists, or a certified nurse midwife, which I found a bit strange. Now, what are some of the national trends in practice? Well, there have been no serious efforts by state governments that presently have full practice licensure regulations to dial back to reduce practice or restrictive practice status for NPs. And over the last 5 years, 7 states, including Minnesota, have moved from restricted practice to reduced or full practice regulatory status. Also, as to the issue of professional or individual liability insurance premiums, While the medical profession has claimed it would be an issue when full practice authority has been brought up legislatively, the current main liability carriers for nurse practitioners do not make a distinction in rates based on licensure status. So that means carriers have not created different rates based on licensure authority, and rates of claims are not higher in states with full practice authority. So what are some of the barriers to full practice licensure? Under the economic theory of regulation, Nobel Prize-winning economist George Stigler, the late George Stigler, points out that an interest group can convince the government to use its coercive power to the group's benefit to improve or maintain its well-being at the expense of others. That's usually consumers. Now, ostensibly, the rationale for health and safety regulation is aimed at reducing risk of sickness, death, or injury. So in the case of establishing regulatory barriers to full practice licensure for NPs, the medical profession is the interest group that has had some national success, including in Michigan, in preventing this scope of practice outcome for many of the nation's consumers. How is Michigan negatively impacted by restrictive practice? First of all, counties in Michigan are designated health professional shortage areas for primary care and mental health care, with a quantitative ranking in the lowest quartile. Moreover, Michigan is medically underserved areas statewide. With shortages in primary care physicians, that is in family practice and internal medicine, and psychiatrists throughout Michigan, there is a need for full practice primary care and psychiatric mental health NPs to meet some of the unmet consumer demand for healthcare services, again, within their scope of practice. Second, these NPs can provide many unmet healthcare services at a reduced cost to patients, insurers, and state and federal government. And third and lastly, Michigan stands as the only state in the Midwest having restricted practice designation, as the neighboring states of Ohio, Illinois, Indiana, and Wisconsin are NP-reduced practice states. And west of the Mississippi River, as Connie showed you on the map, most states are either in full practice or reduced practice states. So the talent drain for in-demand nurse practitioners, especially in primary care nursing, beckons southward and westward. So what are some Michigan public policy concerns? First off, acknowledge the physician shortage and the consumer need for medical services. Next, acknowledge the increasing costs of healthcare services. Then acknowledge the potential healthcare service provider remedies available for Michigan's consumers. Consider allowing nurse practitioners to offer their services to the full extent of their professional competency, and recognize the uncompetitive position Michigan is presently in retaining and attracting nurse practitioners compared to our adjacent states. Now, we do have a legislative remedy for full practice nurse practitioner, and this is from Representative Ken Yonker, who introduced House Bill 5400 in the Michigan House. Now, this bill includes the following major provisions. It defines the practice of nurse practitioners, clinical nurse specialists, and certified nurse midwives. It authorizes nurse practitioners to order patient restraints and prescribe physical and speech therapy. It authorizes nurse practitioners to autonomously prescribe non-scheduled drugs and 4 and 5 scheduled drugs. It requires a nurse practitioner to have delegated authority from a supervising physician to prescribe 2 and 3 scheduled drugs. It adds nurse practitioners to the list of prescribers in the Public Health Code, and finally adds a clinical nurse specialist to the Michigan Board of Nursing. Our conclusions: nurse practitioners are a highly competent, cost-effective, yet often underutilized healthcare professional. The research shows that nurse practitioner quality of care is equivalent, or in some cases superior, to that provided by physicians. I hope I'm not offending the physicians in the audience with that. In Michigan, where there is an acute shortage of primary care physicians and psychiatrists, the full practice primary care and psychiatric mental health NP could help alleviate some of this medical service shortage. Full practice legislation, which has been recently introduced in the Michigan House of Representatives, if enacted, will go a long way to help address Michigan's healthcare service provider crises. Final question: well, what's best for the Michigan's consumer trumps special interest group considerations to maintain the physician's monopoly position prescribing drugs and related medical services. Thank you.
like to thank the Mackinac Center and the Heartland Institute for inviting us to speak today. Today we're going to talk about what this conference is about, free market solutions to problems in healthcare. This is an old solution and a new solution. Understanding direct primary care is the topic. I'm Dr. Richard Armstrong. I'm a general surgeon from the Upper Peninsula of Michigan. So what would a general surgeon be doing talking about primary care? Well, I represent the Docs for Patient Care Foundation. I'm the treasurer. But our president, Dr. Lee Gross, is a national leader in the direct primary care movement. And so this talk is mostly going to be about Dr. Gross and his practice and our experience promoting the idea of direct primary care in America. Why direct primary care? It's because of the rise of the regulatory state and the third-party payment system in the United States, which was really accelerated after 1965 when Medicare passed. And it's related to the overhead created for doctors who are trying to practice medicine under this bureaucracy. It's incredible, and it has been an incredible burden on primary care physicians especially, trying to practice under this these regulatory laws and the current payment systems. For instance, in a general family practice now in the United States of America, in the normal system where you use insurance to pay for primary care, the average visit in the United States with your family doctor is down to 8 minutes. 8 minutes. How can you possibly develop a relationship with a primary care doctor in an 8-minute visit? Any rational person would say you can't. And so the patients are going away disappointed, and the doctors are losing the joy of their practice. They're losing their enthusiasm for their practices, and something needed to be done. So direct primary care allows more time and freedom with patients. Fortunately, a group of doctors from Washington State who formed a company called Q-Liance saw this coming with the Affordable Care Act. So Section 1301A3 in the Affordable Care Act says that a direct primary care practice can be a patient medical home. So it can happen under the Affordable Care Act. This is transparent economically, a direct primary care practice. Take a look at this quote. This is kind of a trick. To all my patients, I invite you to discuss frankly with me any questions regarding my services or my fees. The best medical service is based on a friendly mutual understanding between the doctor and the patient. This is a plaque that was sold by the American Medical Association to doctors practicing primary care in 1953 for their offices. Can you imagine a plaque like that in one of these 8-minute visit offices today? Doctor, could you please tell me, how do you bill me? How do I get paid? How do I pay you? Nobody knows the answer. So now we have direct primary care where doctors like Chad Savage in the room here are doing it in Michigan, and he knows the answers. So what does it cost? This is Dr. Gross's cost. And I should tell you a little bit about Dr. Gross. Dr. Gross's practice is called Epiphany Direct Care. What was the epiphany? About 8 years ago, when he was in practice in Florida, a guy that ran a heating and air conditioning business came to Dr. Gross and said, you know, Lee, all of my employees, my 10 employees, see you as their doctor, and yet I pay these gigantic premiums for my health care insurance. Why can't I buy a high deductible health plan and just pay cash to you for all of them for their primary care? Light bulbs went off, and Dr. Gross thought, wow, is that possible? The answer was yes, it is possible, but it took some work. So what does it cost? This is Dr. Gross's fees. Individual, $50, spouse, domestic partner, $100, family of 4, $135. This is about how much people pay for their cell phone contracts per month, and that's exactly how he markets it. What's included? The things on this slide. Underneath a regular third-party payer system for all of these benefits, you would essentially have to pay about $3,655 per year for these services. You know, maybe some co-pays would be included, maybe not. If you're a single person, that zero on the you-pay side would actually be $600 in Dr. Gross's plan. But that's still much less. These are examples of things that he can do in his office that save you money. So if he does a joint injection, that's included, no charge. It's part of the regular membership fee. If he does a skin biopsy, no charge. Drains an abscess, no charge. Fixes a laceration, no charge. Anything that can be done in his office is covered by the membership fee for the direct primary care practice. The other thing that a direct primary care practice can do is they can make deals with people that are outside of their practice. And the best example is when Dr. Gross first went to negotiate an imaging deal for mammograms for the women in his practice. He did it like, have you ever used Priceline? He did it like Priceline. He went to the radiologists in the area, imaging centers, and he said, hey, do you use your mammogram machine all the time, every day? And they said, well, no. What if I paid you cash for those slots to use your mammogram machine when it's not being used? How much would you charge for the imaging and for the radiologist reading? He said, I don't want to know what you're going to charge me. Just tell me and sign a contract for 1 year. Can anybody guess what that charge is? It's right there, someplace. Not there. $30 for a mammogram. $30. The patient gets the mammogram. He pays the radiologist. He is able to negotiate fees for all of these services, including incredible fees for laboratory services that are way below the normal, what we would think of as market costs. This is leading up to what we call the OMG slide. And the reason it's called the OMG slide is because we were at the State Policy Network in Grand Rapids last year, and when Lee put the slide up that is coming, and you've got it on your table, there was a network person from Alaska who took a picture of the slide with her cell phone and tweeted it out right away and said, OMG, OMG, I'm still trying to wrap my head around this. I can't believe I'm seeing these numbers. So what is this? Lee's on the staff of a hospital in Florida near Northport, and this is an example of an itemized hospital bill for someone who showed up in the emergency room with abdominal pain at his hospital. You've seen these bills. You probably can't understand them. Most of us can't either. But you look at these charges, you have it on the table, they're incredible. The charges are just unbelievable. How can this happen, people ask. You have this on the table too, and this is a summary of those charges for this patient. Now, I must tell you, the patient was a retired family physician in his early 80s who knew Lee. So after he had his workup on a Saturday, this is what it cost, nearly $20,000. That's the bill he got. He came with the itemized bill to Lee's practice and said, could you have done all these things in your Epiphany Health Plan in your office? Lee said, sure. And then he said, okay, could you itemize these things out and tell me how much would it have cost if I came to your office on Friday instead of the emergency room on Saturday? And this is the answer. $278.79. This is real. This is real because all of the middlemen have been cut out of the transaction. This is a free market solution to healthcare, and we're doing it in Michigan right now. So one of the things that needs to be explained is what's the difference between direct primary care and concierge medicine? This gets confusing, and there's a paper on the table called Understanding Direct Primary Care that came from our website to help you understand this. But the bottom line is this. In a direct primary care practice, no third-party involvement is happening, not the private insurance companies or the government. This is a direct financial relationship between the patient and the doctor. Completely transparent, the patient knows exactly what they're getting. It exists, and it's frankly beautiful. In concierge medicine doctors still bill insurance companies, but they add extra things. So they might be available 24 hours a day. They might give you their cell phone number. They might make home visits. They're extras. So the people that are against direct primary care and free market solutions will often try to conflate these when they talk, and you'll have to be careful and listen to that. Because they'll say, oh, direct primary care, that's just for the rich. Nonsense. It's for anybody that can afford a cell phone. It's not a rich man's service. So there are things that have to happen, and we're still working through that. Fortunately, in Michigan, the law was changed in 2014 with the help of Danny McCorry, who wrote that paper from Heritage that's on the table, and Senator Pat Colbeck, who I hope can make it here. The law was changed to redefine the Michigan insurance code so that direct primary care practices are not considered a risk-bearing entity. A risk-bearing entity can be regulated as an insurance plan. DPC practices are not that. The other thing that's happening in Michigan via Senator Colbeck is he's exploring utilizing the direct primary care model in a pilot for Medicaid programs. This has already been done in Washington State, and a pilot program there reduced the state's payments to Medicaid by 20% through Q-Lions. At the federal level, legislation is pending. Senator Bill Cassidy from Louisiana is working on this now to allow or to change the IRS code so that a health savings account can be used to pay for the membership in a direct primary care practice. They're also working on new payment models under the MACRA law in the APMs, and we can talk about all these acronyms when it comes time for the questions, to develop a new payment model in Medicare so that direct primary care can be used for Medicare patients. So this is really a free market solution and an incredible solution. And one of our good friends, Josh Umber from Kansas, who was a pioneer in this and has the Atlas MD practice in Kansas, quotes this to the media all the time. Direct primary care is 2/3 Marcus Welby and 1/3 Steve Jobs. And the reason it's 1/3 Steve Jobs is you can use all kinds of new technology to communicate with patients. You know, Josh says to me, Dick, when I come into my office on Monday morning, I sit down with a cup of coffee and I answer 50 emails. Those people want to know their test results. They want to know things, they have questions. I spend time at my computer and I answer all their questions. Maybe 3 or 4 of those have to see me in the office and we make an appointment for the afternoon, and then I spend as much time as I need with them because I'm their doctor. I'm their real doctor. I am their direct primary care doctor. So that's the presentation. Really happy to entertain any questions in the question and answer period, and I know Dr. Savage would be happy to help with that. Thank you so much.
Hi, I'm Thomas Stratman. I'm a Cato Scholar at George Mason University, and I'm a University Professor of Economics and Law at George Mason University. I would like to thank the organizers for inviting me, and I'd like to thank the members of the audience to take time out of their busy schedules to attend this forum. I've studied one type of health law, state health law, that is particularly harmful for patients and for innovative medical providers. These state laws are one important reason why we do not have less invasive medical procedures, why we do not have less costly medical procedures, and why we do not have more safe medical procedures. Moreover, these state laws explain why many millions of Americans do not get proper screening to detect precancerous growth. This is one reason why we have millions of unnecessary deaths in the US. Further, these laws limit the ability of healthcare providers to provide innovative and cost-effective healthcare. These laws are certificate of need laws. Certificate of Need, or CON, or CON laws, as they are sometimes called. These are laws that require state agency approval before an already licensed healthcare provider can offer new medical services, or before an already licensed healthcare provider can expand medical services. Importantly, Certificate of Need laws have no public health justification. Nonetheless, and without a public health justification, these laws require providers or potential providers to first obtain permission from state regulators to provide innovative healthcare services. It turns out that in 36 states, including Washington, D.C., there are Certificate of Need laws, meaning it is illegal to open up new medical facilities or to purchase certain types of medical equipment without special permission from state regulators. And by requiring special permission, these corn laws limit patients' ability to obtain medical services. Corn laws, in fact, are designed to limit the provision of medical services. Corn laws limit the number of medical services is not a mere byproduct of these laws or an unintended consequence. It's actually done by design. Why? Because it is written into these laws that new competitors cannot take any customers away from existing providers. These laws started out in 1964 when the state of New York adopted a corn law. In the following years, a few more states adopted corn laws. At the end of the 1970s, the federal government decided corn laws are a great idea, and they tied federal funding to the adoption of these laws. So basically they said to the states, have these laws or you don't get federal funding. So all states but Louisiana adopted a corn law. And the idea was, well, we want to save costs. One bed built is one bed filled, went the saying then. So if we have excess capacity, it will be used, so let's reduce capacity, and therefore we can save costs. Well, by the beginning of the 1980s, the federal government realized this theory doesn't hold water. We just don't see any cost reductions due to these corn laws. And so they repealed the semi-requirement for states to have these laws. Subsequently, about 15 states dropped the laws. The other states still have these laws on the books. And then the justification for these laws changed a little bit. Instead of justification being cost reduction, the justification was coming towards charity. What does it mean? Well, by requiring special permission and keeping new entrants out, existing providers have a semi-monopoly. So whoever has a certificate of need has a semi-monopoly because potential entrants are held out. Monopoly means monopoly profits. And so the state thought, well, I'm giving you a monopoly, you receive monopoly profits. In exchange, you should provide more charity care, or indigent care, as it was called. And so what do you think? Do we see that? Do we see more charity care by hospitals in states with corn versus non-corn? I will come back to that. Now, to be very clear, there is no health reason, or so to speak, there's no public health or safety justification for corn laws. Separate state and federal regulations govern who can practice medicine, what qualifications are required, and what procedures are permitted. Corn regulations amount nothing else to a government permission slip to compete. They restrict competition by protecting established businesses from fair competition. They amount to giving established businesses a cartel over new companies or new medical providers. And basically, they require government permission for services for which the government has no objections otherwise. Let's take a look at the map of the US to see where these certificate of need states are located. 36 states have certificate of need laws. Those are in, I guess this color is green, dark green. So they're located primarily in the south, northeast, a few in the west, and Michigan is one of the states that has a certificate of need law. The certificate of need laws are not uniform. They vary with respect to the number and the types of medical procedures that are required in terms of getting permission. To give you a sense of what kind of hoops an applicant has to jump through to obtain a certificate of need to basically do his or her job for which he or she was trained in medical schools and in hospitals, first you have to fill out a letter of intent. It turns out that's often where it stops. providers realize they will not get, or applicants realize they will not get a certificate of need, and they don't pursue it any further than up to the letter of intent. Next step is an application, which can go up to 6,000 pages. And it comes with a hefty application fee of up to $45,000, depending on the state. Then, after a while, there's going to be a public hearing. Now, there's something very interesting going on in the public hearing. There, existing providers, like hospitals and other medical providers, they can oppose the application. They say, we don't want any competition. You have to reject this application. This is crazy. It is like McDonald's has a say whether Burger King can open a franchise in the state. So after this is being done, there's a fact-finding conference, and some, depending on the state government or body they have instituted, there's a determination whether there's a need for the service. And then they give the verdict. Often, the cost of this entire procedure is often much, much more than the $45,000 I mentioned there, because the entire thing can turn into a full-blown litigation. So these are real barriers to entry. This is not simply paperwork that an applicant has to go through. Over here you can find this. This is sort of hard to read on the left-hand side. You can see that on the Mackinac webpage. This is the number of con laws by state. On the vertical axis is the type of the name of the state, the abbreviation. On the horizontal axis are the number of procedures regulated. Vermont, with about 30 different con regulations, has the most. Michigan is around number 8 in terms of the 8th most regulated state, with about 18 to 20 con regulations. And there are, then you see some other numbers, and we can look at these slide in detail on the Mackinac website. To give you a sense what is regulated, I'll just give you a few features. I said up to 30 different items are regulated, but the purchase of MRI scanners is regulated. So you have to ask for permission if you want to have an MRI scanner in your office. The same with a CT scanner. Further, if you want to offer an ambulatory surgery center, so these are centers that do outpatient visits primarily. If you want to open that, you have to get permission from the state regulator. About 20 states regulate ambulatory surgery centers in that way. Further, hospitals in about 20 states have to ask for permission if they want to add another hospital bed. This is just some examples of what these regulations entail. They will give you sort of a feel and some context to what I'm talking about. So we at Mackinac have done a number of studies on this. We wanted to see, do these certificates of need laws live up to the promise? Do they have more charity care? Do we see more provision of services in rural areas? Do we see lower prices, or do we see higher quality care? And what we found, we looked at the data, and we see states with con laws, they have fewer hospital beds, they have fewer MRI machines, they have fewer CT scanners. And you also, in these states with con laws, you see fewer hospitals operating, and you see fewer non-hospitals or hospital providers, so meaning private practice. I refer to those as non-hospital providers. And they reduce, not surprisingly probably, the utilization of services. If there are fewer MRI machines, fewer CT scanners, then you also kind of think, well, there's probably less access to care. Yes, you see that in the data, there is less utilization of medical services. Give you some headline numbers, and then I will talk about Michigan specifics. Overall, you see about 1/3 fewer hospitals in states with con laws. So what does this mean, to put it in context? In a town of about 500,000, there you see in the data that those towns have about 6 hospitals, if they are located in a state without a con law. If you look at it, the same town, would it be located in a state with a con law? Instead of 6 hospitals, we would have 4. so about a 30% reduction. Similarly, you find roughly the same number in terms of MRIs, in terms of non-hospital providers offering MRIs. So, meaning private practices, you see fewer private practices offering MRIs in states that regulate the purchase of MRI machines. And you also see fewer hospital beds, roughly again the same order. Fewer, less capacity, less choices for patients. So what is the source of these findings? We collected data on certificate of needs and utilization and MRI machines, hospital beds, and all these different measures for all 50 states, including Washington, D.C., looked at it over time, and used these data to come to some conclusions. And we can apply these conclusions to each of the states, including Michigan. So let me tell you what happened in Michigan. How does Michigan look like because of corn laws, or its specific corn laws? Again, same as what we see nationally. There are fewer hospitals in Michigan now than there would be if Michigan had not have a corn law. There are fewer ambulatory surgery centers, less availability of imaging services. So this is what I'm referring to in terms of CT scans, MRI scans, and PET scans. And also, interestingly, what you see in the data is that patients residing in corn states, they tend to seek, or at least some of them, do seek medical services out of state. Again, this is just simply a function of less availability of medical services in states with corn laws. Some specific numbers. So the blue bar tells you what's going on in Michigan right now. The yellow bar tells you what would be Michigan like if it would not have a corn law. And so here we're looking at the number of hospitals. So currently there are about 170 hospitals in Michigan. If Michigan were to get rid of corn, then over time we would have about almost 250 hospitals in Michigan. Let's look at ambulatory surgery centers. Currently in Michigan, we have 91 ambulatory surgery centers. These are data as of 2 years ago. Without a certificate of need law requiring permission to open up an ambulatory surgery center, we would have about 106 nowadays. Then let's look at MRI scans. So these are data actually for Medicare, and the conclusions extend to the rest of the population. Currently, we have about 45,000 MRI scans by seniors in Michigan. If there were no corn law limiting the purchase of MRI machines in Michigan, then 68,000 seniors in Michigan, or they would have received an MRI scan, or put differently, there would have been 68,000 MRI scans, so roughly 1/3 more. And also with respect to the last slide on imaging services, again, we see a similar increase in CT scans if Michigan were to adopt or get rid of CT corn legislation. Now, what do we conclude from this? First of all, corn laws, we said, is a government permission slip to compete. You have to get regulatory approval, which is very costly and time-consuming. Sometimes, or often, applicants give up in the middle. Would-be competitors can oppose the application, and the outcome of this application is often very uncertain. Corn laws provide existing providers with a quasi-monopoly. It insulates them from fair competition. Corn laws reduce access to care. We see fewer opportunities to obtain MRI scans or CT scans in states with corn laws. We also, in a study that is forthcoming, we document there's no improvement in quality of services in states with corn laws. If anything, you see lower quality of service, medical services in states with con laws. You see higher readmission rates and higher mortality rates in hospitals in states with con laws. And they prevent innovation. Why? Because state regulators are even less likely to offer a certificate of need to an innovator who wants to, for example, offer virtual colonoscopy, as has happened, for example, in the state of Michigan. Finally, let me go back to the charity care justification for certificate of need laws. I said it's written in the law that hospitals with a certificate of need are supposed to provide charity care. So we compared the amount of charity care by hospitals in states with and without certificate of need laws. What is the difference in the amount of charity care? The difference is zero. There's no higher levels of charity care in states with con programs than without. And this is just the upshot that also then shows that con simply does not work and harms patients and does not fulfill its promise. Thank you.
All right, thank you all for those presentations, and I will, while the rest of you are formulating your brilliant questions and my colleagues are collecting them, I'll ask a question of my own because I can. And so to talk about nurse practitioners, on that question, I wondered if you, either one, Thomas or Connie, if you could talk a little bit about how nurse practitioners can operate in a more cost-effective, efficient manner. That was one of the things that you mentioned several times. I just wondered if you could talk a little bit about how they're able to do that under the current structure.
Well, bottom line is nurse practitioners are a lot less expensive than physicians, and they provide comparable care. The average salary for a nurse practitioner starting out in school when they graduate is around $80,000 in Michigan. Some of my graduates might make $90,000, but that's their typical salary. So if they're in a practice and they're providing the same amount of care, they're a lot more cost-effective provider.
Okay, thanks. I have a question for Thomas, too. One of the things that I've heard as an argument in favor of certificate of need laws is one based on rationing. So basically the argument is that there won't be enough hospitals in the right places if we don't have certificate of needs laws. So, you know, Michigan, and maybe in rural areas, there will be fewer hospitals because all of the providers will want to go where the populations are largest and where there's the most money. Can you address that concern?
Yes, one of the justifications for con laws is that they will help hospitals in rural areas to survive. And we looked at hospitals in rural areas in con states versus non-con states. And what we see is actually fewer hospitals in states with con states. They do not gain. Hospitals in con states in rural areas are no better off than in non-con states. In fact, there are fewer.
And Dr. Armstrong, for direct primary care, you talked a lot about sort of the this being done for a generalist, for primary care physician. Has there been experiments or examples for specialists for creating these kinds of arrangements with patients?
Yes. This on? Yes. The specialists that have been doing this for a long time, in fact, are the specialists that don't do a lot of technical things like psychiatrists. So psychiatrists have been direct pay for a long time, but there are other practices, and maybe Dr. Savage can add a little bit to this as we talk, that have been experimenting with this, lots of different practices. And in fact, in surgery, we're doing direct cash pay surgical care at the Surgical Center of Oklahoma, in Oklahoma, where there's no third party involved at all, and it's all ambulatory care. Prices are up front. You can go to their website. They're posted. It's working beautifully. What we need in the United States is to get rid of these con laws so we can have more surgical centers of Oklahoma.
That's actually a great point, because that's something, a question someone raised here was, has anyone given thought to sort of the combination, the impact that could be had if we had more direct primary care and also got rid of certificate of need laws, to see, how that could reduce costs?
Actually, the Docs for Patient Care Foundation is doing that now. I mean, we're focused on direct primary care, getting rid of certificate of need laws, another problem called maintenance of certification, which is specific to physicians, and then meaningful use in our terrible economics regarding EMR systems in the United States right now.
Back to the nurse practitioners, we have a question here about sort of the brain drain that might be happening with nurse practitioners in Michigan. We have a lot of high-quality nursing schools in our state, taxpayer-funded, some of them. And do we have evidence for that Michigan taxpayers are paying to train nurses who then go and provide services to the fine taxpayers of other states?
There is data on the number of nurse practitioners per capita in each state, and Michigan is below the national average. I think the average number of NPs per state nationally is 60 per capita, and I think Michigan is at 47, and states with full practice have higher NPs per capita.
Okay.
So, and anecdotally, a lot of my students say, why should I stay here when I can go, to a state where I'm going to be allowed to practice to the way that I've been trained.
And I wonder, in states where they have full practice, are nurse practitioners also able then to earn more money?
The salary doesn't really change that much. You can, look it up on salary.com. Geographically, the salary changes a little, but, based on geographic region, but no, it's not really that much different.
Okay, this one's for Dr. Armstrong. You mentioned that direct primary care is happening here in Michigan. I had several questions about asking how does that work, or can you currently use a high deductible health plan to pay for this? And so people are curious about what's happening here specifically in Michigan.
Well, the good thing in Michigan, as I mentioned, is that with the help of Senator Pat Kolbeck and the Michigan State Medical Society, we were able to pass the legislation to change the Michigan State Insurance Code so that direct primary care practices are protected from regulation. That helped, and that's one of the reasons that direct primary care practices are now growing in Michigan. Concerning the insurance issue, that's being worked through nationally right now. As you know, the Affordable Care Act limits what kind of insurance both employers can offer and can be offered in the exchange plans. And so there are no specific, what we would call wraparound insurance plans that work with a direct primary care practice yet. What happens, though, is if you follow what's happening in many of these practices is that the deductibles are so high in some of these insurance plans that people will be happy to pay this $50, $60 monthly fee to see a doctor that is their personal doctor, because they'd have to pay their deductible anyway. The other thing that needs to occur that would be nice in these insurance plans is to be able to count that fee toward the direct primary care practice as part of a deductible in their insurance plan, so that it would be incentivizing people to have that kind of a plan.
I have another question here about nurse practitioners. So there seems to be some concern that if more physicians, medical professionals are able to prescribe drugs, there could be more potential for abuse in prescription drugs, particularly with opiate abuse and other, very addictive prescription drugs that we use. Has there been any research done on that, or evidence of that being a problem when we expand who can prescribe drugs?
Not that I know of. Nurse practitioners, just like physicians, have to obtain a DEA number to prescribe controlled substances and have to abide by, the same rules and regulations when they do that, though it's more restrictive in Michigan because, you know, we are prescribing in a delegated way in Michigan. So not that I know of. I don't know if anyone has tracked whether or not there's more, you know, prescription abuse kind of thing with expanding. I have a tendency to doubt it because of the statistics that Tom's had about liability. So, which makes me think no, because malpractice rates haven't gone up in those states with full practice.
Right. That was particularly interesting that it really didn't matter in regards to whether it was reduced or restricted or full practice. I was kind of expecting that, but that hasn't been the case.
Okay, very good. Dr. Stratman, for you, so one of the arguments for con laws is that it will sort of, create the right amount of medical service for a state. I'm wondering, and we have a question here along these lines of why is there a tendency for hospitals to overexpand? I mean, is that a case? Is there something unique about hospital provision that creates an incentive for them to offer more services, buy more empty beds, buy more equipment that they don't need? And is con addressing that problem that's inherent in the hospital service market?
Well, it has been a claim for a long time that hospitals or other providers may treat aggressively or perhaps overprescribe, and that is sort of one justification for limiting capacity, or has been. However, the data just do not show this. It's not shown out in the data that there's systematically more higher prescriptions in non-con states than in con states, especially if you compare the 15 states in the US without a con law with the 35 states with the con law. There's no real difference between the states in terms of medical service provisions, and it shows that the world does not go to hell without a con law.
I wondered if you could comment too on the on some recent Supreme Court, one recent Supreme Court case on a separate issue, but it seems to apply to, or seems like it would have some relevance to the idea of certificate of need, and that is in a case in North Carolina where the Supreme Court ruled that a board of dentists basically could not determine which people could offer some dental services. Are you familiar with that case?
Teeth whitening.
Yeah, specifically with teeth whitening. I wonder if there's any application here or any lesson for certificate of need, because it seems like you have sort of a similar relationship where medical professionals are determining who else gets to practice.
Yeah, it's very, very similar, the con laws versus, and the states you mentioned, North Carolina. And there are some lawsuits actually going on right now trying to overturn some state certificate of need laws.
Okay, do you know which states those are?
One is in Virginia, and another one I believe is in Georgia.
Okay. Good, excellent. To the nurse practitioner issue, it seems like we have a really good natural experiment because we have a healthy mix of states that have full practice, good size we have reduced, and then a good size restricted. You mentioned that there's a lot of research that's been done on this, but I wondered if you could elaborate a little bit more on the research related to sort of comparing the states in terms of outcomes for patients in the various states, depending on their the practice that they allow.
You mean as far as health outcomes of the population?
Yeah, I mean, so what are the differences that we see between the states who have full practice and the states who have restricted and states that have reduced?
I can't quote that without looking at an article that compares the states. It probably is out there, though. I think we know some of the health outcomes in Michigan are not that great. We have high infant mortality, and we are a restricted practice state, but I'd need to pull up that research.
Okay.
And don't want to misquote it.
Okay. So, Thomas, I'm going to give you another argument on con laws that I'd like you to address. I remember when you all did your report maybe last year on Michigan con laws and kind of the impact that they have, and I think in there you mentioned how many more hospital beds could be provided in Michigan. And one of the responses I heard on that was, well, we don't need more hospital beds because we only, at any given time there are only a certain number of beds in use in Michigan. So what's the point of having a bunch of empty beds? And that would actually be, sort of wasteful. Can you respond to that line of reasoning there?
I mean, the number of patients to hospitals or in hospitals is not always the same. Sometimes there is a shock and there's going to be many more patients. So hospitals want to have some extra capacity so they do not have to turn people away.
Well, one of the comments that I would make about the certificate of need laws is that I think it's important to not look at them in isolation. There's a lot of incredible disincentives and strange incentives in our payment systems that affect this. So, when you're talking about people wanting to build certain things, for instance, onto a hospital, they might have a financial incentive to do that is an artificial, strange incentive coming from a government payment program or maybe a Medicaid program or some type of alteration in a private payer mix that makes them decide to do that. And so what's actually happening in that situation is that hospital is responding to the market in a rational way, but it's a dysfunctional market. And so it's hard to look at these things in isolation and just say, well, if we get rid of all the con laws, it's going to do this. We have to change somehow the way we work our payment systems so that they become a little bit more coherent.
All right, good. Well, I've gotten through all of our audience's questions, and I wanted to just give each of you a chance to make any final comments. And in particular, I think it might be beneficial for this group to be reminded again of the Michigan legislation that's currently being debated on these issues, so that they could maybe tune into that and pay close attention. So, Thomas, I know you mentioned in your presentation some of the legislation regarding this.
Yes, Ken Yonkers' bill, which is, I believe, in the Health Care Committee and the Michigan House, is not moving right now and languishing. So anyone that would be interested in pursuing this and supporting it, please give his office a call. That would be very helpful.
Dr. Armstrong, if you could.
Well, a couple things. First, I'd like to thank you for inviting the Doctor Patient Care Foundation to be here, and you can go to us at d4pcfoundation.org for more information. As far as the legislation in Michigan, currently regarding the direct primary care model in Medicaid, you would need to contact or work through Dr. Senator Pat Colbeck's office, and he had a representative here, but I'm sure you can get in touch with his office. I know that he's working on a pilot program to help in the Medicaid area.
There's something that we should talk about, and that in front of the legislature right now is an anti-MOT bill, maintenance of certification. And that bill says that maintenance of certification should not be required for hospital privileges, should not be required for insurance payment, and one other thing which I can't remember right now. So if people are interested in free market and this ridiculous maintenance of certification law, which has turned out to be in Newsweek, if you want to read about it, strictly a cash cow for a few organizations, has no basis in fact, has actually been shown to decrease patient care, not improve patient care. So it is something that we should get behind to move right now.
And that's called maintenance of need?
Right, it's maintenance.
Of certification
Maintenance of certification, okay. And there's some legislation in Michigan
is pending.
pending, okay.
So we gotta
It's been
move.
introduced, okay. All right,
You can find out more about that also on the Doctor Patient Care website.
okay, great.
And MSMS has written legislation, the Michigan State Medical Society, because some crazy person passed that through the House of Delegates.
Okay, well, we'll pay attention to that one too. Thank you all for coming today. We appreciate your attendance. Just for future reference, we have another Issues and Ideas Forum coming up on June 2nd. And the Mackinac Center has conducted a thorough survey of all the private schools in Michigan. And we're going to be presenting the findings of that survey. And it has in there how many students are enrolled in private schools, what kind of capacity private schools have, what kind of teachers are teaching in those schools, what the average tuition rates are, and things like that. So it's going to be an in-depth look at the private schools in Michigan, which is something that data is not easily available, so we'll have some new information about those. And then just a reminder, too, if you want to stay tuned in to Michigan politics and what's happening in Lansing, I encourage you to check out our app called Vote Spotter. You can get it on the Google Play and the Apple App Store, and there you can it'll put in your address and it'll tell you who your representatives are and give you important updates on legislative actions that they've taken in Lansing and give you an update right on your phone, so it's an easy way to stay in touch with what's happening in Lansing. So thank you all again for coming, and please join me in giving our panelists another round of applause.